Okay, I think we'll get started. Thank you all for your patience as we got our technical glitches worked out. Welcome everyone to the Department of Geriatric Medicine Grand Rounds. This is an extra session for an extra special guest that we have. I'll go through some of our housekeeping issues first, and then I'll introduce our guest. This CME activity is sponsored by the Hawaii Consortium for CME, a joint venture between the HMA and the John A. Burns School of Medicine. At this time, please enter the name and credentials of everyone viewing Grand Rounds for CME attendance purposes. As a reminder, evaluations are required for CME. You can find the evaluations by following the link in the chat or on our website or in our email advertisements. Your comments are important to the planning committee. As you know, all sponsors of CME are required to execute a conflict of interest policy. Dr. Aronson has disclosed that she has no relationships with commercial supporters that could be perceived as a conflict of interest in the context of this presentation. I'm so pleased to introduce our speaker today, Dr. Louise Aronson. She's a leading geriatrician, writer, educator, professor of medicine at UCSF, and the author of the New York Times bestseller and Pulitzer Prize finalist, Elderhood, Redefining Aging, Transforming Medicine, and Reimagining Life. At UCSF, she has served as the founding director of the Care at Home and Optimizing Aging Project, Pathways to Discovery program, and the Northern California Geriatric Education Center. She's also the chief of geriatric education at UCSF. In addition to her clinical practice and teaching, she leads the Age Self-Care Program, UCSF Medical Humanities, and she's the clinical lead for the Senior Hub of the San Francisco Department of Public Health COVID-19 response. She serves on the COVID State Force COVID Vaccine Allocation Work Group for California. She has received the Gold Professorship in Humanism and Medicine, the California Home Care Physician of the Year Award, the AGS, American Geriatric Society Clinician Teacher of the Year Award, and her writing credits include the New York Times, Atlantic, Washington Post, Discover, Vox, JAMA, Lancet, and New England Journal of Medicine. She was also featured on NPR's Fresh Air Today, NBC News, CBS This Morning, Morning Edition, Politico, Kaiser Health News, Tech Nation, and The New Yorker. We're really honored to have you here, Dr. Aronson. Thank you so much for being with us.
Thank you. It's a pleasure to be here, although I am where I've been for like the last year in my chair. Anyway, I wish I were with all of you. And a shout out to Gina. Hi, Gina. I see your name out there. Gina, who used to be with us. Anyway, it is very nice to be here virtually. And I'm going to talk about prejudice and pandemic. So let me pull up my slides. Here we go. So I feel like COVID-19 has shown us a lot, for better and worse, about aging and healthcare in America. I've got my requisite learning objectives, and it's really, I'm going to give you my biased view of the last year plus. I realize you guys have been better off than many of us, but still this has taken over lives and the focus of the healthcare system to a great extent. Think about how we can combat the structural ageism and racism in pandemic healthcare and healthcare broadly writ, and then think of how we can use what we've learned to the betterment of older adult lives and medicine. So I'm going to change slides here just to make it clear that this is my biased version. It will, however, be evidence-based. In some cases, I'm going to use newspaper clippings, and that's mostly because this was all so new and fast-breaking that the newspapers often had important information months before medical publications did. And they did a great job of rapid and online publications, but still for each thing I show, there is later or on the same slide the evidence base on which it is predicated and what deserves it there. Okay, so I'm going to start in February 2020, which seems about a decade ago. Actually, the head of health for the city of San Francisco at the year mark we had this meeting, and I knew him when he was younger, a very good-looking man, and he just looked haggard. And he said he decided that each COVID year was like a dog year, so that's why we all looked 7 years older. Pretty good joke. So we'd heard from China, Iran, Italy that this was a disease that really struck older people harder. And so surprise, surprise, the first outbreak, not the first case, but the first outbreak in the US was in a nursing home outside Seattle. In March, we saw, we seem to have to prove this each time, that what happens elsewhere also happens here. So we learned two things: that it was far, far worse than the flu, and the flu is bad for old people. Um, and also, in some ways, we in geriatrics are often talking about how, functional status matters more than chronological age. But the very clear upstepping of the curve with each decade of aging shows that age itself is also a factor in disease vulnerability. We will see, however, that disease vulnerability is not an exclusively biological construct, that our policies and social behaviors make a big difference too. The other thing worth noting in terms of particularly frail older adults was that we told people not to go outside, but we didn't tell them how to get basic things taken care of. So this was a series of tweets from a young woman who'd gone to the grocery store and was called over by a couple in their 80s who were afraid to go in lest they die, but had run out of food. And so they handed her money to buy their groceries. So well, it seems to me one thing we could think about is when we tell people not to go out, we should think about how their basic needs get met simultaneously. It's a little bit like when you're scrambling to make vaccines, you might simultaneously begin your scrambling to figure out how to distribute them in a just and efficient way. I don't know if some of the others of you who are members of the American Geriatrics saw this, but very early on, the first time I remember noticing it, it was the end of the first week of March. There were people on the AGS chats talking about what counts as a fever, and don't we think that maybe fevers are lower in old people with this disease as they are in so many others? And also, what symptoms are you seeing? A colleague of mine at UCSF said, well, just because we see atypical symptoms in elders for all other conditions doesn't mean they should expect it for this one. And sure enough, we did. More on that later. In April, San Francisco and many others were sort of still dividing things by traditional. So over age 60 and under age 60, we did not have a spring surge. So you could see the vast majority of cases were age 60 and older. And also that because we had such a small number, the curve doesn't look as it looks elsewhere. I like that there were 3 in a younger age group, partly because it shows that age is not the only risk factor. People with multiple chronic diseases are at risk, and at the same time, people over age 80 are at greatest risk for death. Around this time too, much of the world was surprised to learn that we don't collect very good data on people in nursing homes. There were at this point now getting to be many outbreaks, particularly through the Northeast. And at this time, 36 states were reporting data, but it turned out it was apples and oranges and kumquats and kiwis and mangoes, right? So you didn't know what to do with the data because different states were defining long-term care facility differently. They were including residents and staff together or separately, how often they checked things. There were incredible variations in data in the states for which we were getting data, and there were many where we didn't. And despite the paucity of data, the inadequate data, we already knew this April 23rd. So really the first outbreak was, 7 weeks earlier. There were already 4,000 facilities that we knew of with outbreaks, 51,000 cases and 10,000 deaths. And that was when most places couldn't get testing. So it was spreading like wildfire. But most older adults don't live in facilities, they live in the community. I often ask our medical students what percentage of older people live in nursing facilities, and I generally get answers ranging from 40 to 90%. The truth, as most of you here will know, is at any one moment, 2 to 3%, again, depending on how you count long-term care facilities, though the lifetime risk is higher, particularly for women. But in the state of California, our governor, thought he would cut all services to homebound older adults because, of course, you didn't want people going in to see them and bringing disease. This shows the level of understanding of older people at government because, of course, if those people didn't come in, these older adults were going to have to go into nursing homes, which was the place you were most likely to die in America at that moment. Luckily, we were able to make a lot of noise and defeat this very bad idea. Part of why there was so much trouble in nursing homes was that they weren't given PPE. They weren't really counted as part of the healthcare system. Now, there were other parts of the healthcare system where people weren't getting PPE or testing, but nursing homes considered not part, healthcare systems being prioritized, really weren't having testing or PPE. And this was at a time where finally by May, it was starting to be a little easier in some places. So if you were part of the federal government, you could get tested easily. This was an article from an anonymous famous actor saying he was disgusted at how easily it was to get tested if you were a famous actor. We've also seen throughout the pandemic how if you were an athlete, you could get tested daily, but if you were in a nursing home with an outbreak, you had trouble getting testing. Ageism, not new by any means, raised its head in all kinds of ways, from boomer remover to let them die, they don't matter anyway on Reddit, to this from a person called Bethany Mandel who said, "You can call me a grandma killer." And I like this tweet. Actually, I don't like anything about this tweet, but I like this tweet as a pedagogical statement because her photograph for her Twitter is herself with a child. So she is what the geriatrician Joanne Lynn would call a grandmother in training. And yet the problem with aging seems to be that people find it inconceivable that it is a condition that will affect them too, as it will affect most of us in our lives, as opposed to so many other things where we can other people. This is actually one that will come back to roost. And yet this from Time Magazine, The Road to Recovery, how targeted lockdowns for seniors can help the US reopen. Linguistically, I like this one because it's almost as if there are people who are seniors and then there's us, we people who matter. We can reopen, we can restart our lives as long as we lock up those seniors. And this from the ethicist, Peter, oh no, what's his last name? That's terrible. Anyway, he's profiled in the New Yorker this week. I obviously haven't read it yet. Asking whether age discrimination is acceptable. And again, this is at the moment of a racial awakening for the nation. One can argue that too was quite belated, but it's interesting when we're finally standing up to one kind of discrimination, people are arguing that another kind is acceptable. This audience will know that elder abuse, like other forms of abuse, is intentional act or failure to act that creates a risk for an older person. So I would argue that much of the federal, state, and local responses to COVID-19, at least at this point, were structural elder abuse, so baked into the very systems. I saw this in my own city and state where there was essentially, maybe one person or two people at the state level who knew anything about older people. We were still having to routinely define the differences in oversight, in whether nurses were on site or not at assisted living versus long-term care, what was available to people in communities, what was not. Meanwhile, they have huge segments for children and adults. But the structural elder abuse also was that nursing homes didn't have to report pre-May COVID deaths. So if you were an older person who died in a nursing home before May, your life literally was not counted. And then in May, the federal government announced a whole week of PPE for places in outbreak, where you have to have weekly testing. And in San Francisco, we saw that people, it generally would take the better part of 2 months to get a facility out of outbreak. So they were giving them 1 week of PPE while people died. The CDC did make improvements, but this was the first time they really broke down old age into decades. And actually they lumped younger people for a change. Usually younger people are broken down, but you can see here the light blue color is people under age 24, and then it goes up by a decade until you get to 85 and older in red with the highest risk by far. This was showing the death rates in the first surge in the spring, mostly in the Northeast. Notably, policies and social structures make a huge difference. So this shows COVID-19 deaths in long-term care around this era. And the deaths in Minnesota and Rhode Island were literally 4 times the recorded deaths in Nevada and New York. So how can that be? Is there a biological reason why people in Minnesota or Rhode Island would be 4 times more likely to die from COVID? Of course not. This has to do in part with the state of long-term care facilities, with how good they were at measuring. Minnesota and Rhode Island seem to count lives better than New York and Nevada. Now, Nevada has low government interference, so that's why that happens there. And in New York, they literally weren't counting. Their surge was horrific, and they were not allowing transfers from nursing homes to hospitals. And they were simply not counting people in those places. So the denominator was larger and the numerator was poorly counted. Black and brown lives mattered in so many ways at this point, including in the huge race gaps in COVID-19 deaths. What you can see on the right here is a chart from the Brookings Institute looking at death rates by, by race. Blacks are in orange, Latinx in gray, and whites in that bluish color. And at each age range, you see that whites have the lowest death rate. Most notable here, perhaps, is the fact that there are these huge disparities in old age, and the disparities among younger people were greater still because of the opportunities or lack thereof for advancement, so that most essential workers, most people who could not work from home, were people of color who had to risk their lives daily. We saw this play out in a variety of ways, including in nursing homes where facilities with a high Black share had twofold probability of cases and outbreak sizes. And the really interesting thing here was that if you controlled for all the things medicine usually thinks accounts for these problems, you still saw these disparities. So you could account for income, type of health insurance, comorbidities known to be risk factors for COVID, and public transit use by staff, and you still saw differences based on race. That is baked in racism, structural racism in our system and health system. Early on in pandemic too, many of us were noting how the lockdown was really harming older people. There had already been grave concern over isolation and loneliness being particularly lethal for older people, actually for people of all ages. And what we were seeing clinically was some despair and increase in attempted suicides, people really saying they felt as if they were in prison, or the things they once looked forward to, they felt were not going to be possible in their lifespan. But stay tuned on this one, because as with all things aging, this changed tremendously, such that by the end of the pandemic, the group least likely to have despair was older adults. Not all of them, but a good proportion of them. And that's one of the untold stories of aging. In July, we saw about excess deaths and that they were particularly pronounced among older people, with a variety of reasons cited for them. As I said before, there were lots of places where people simply couldn't get tested. We increasingly saw atypical symptoms, and yet you will see that the CDC and most state health departments still do not list atypical so-called atypical symptoms, which are actually typical in people over age 80, still less than the average in people over age 60 as a large group. But very common, despite the fact that they list symptoms particular to kids on kid pages. A lot of people were afraid to seek needed medical attention because they were told not to go into hospitals, that they were death zones, and a variety of other reasons we'll touch on a bit later. The first study that really looked at a bunch of studies about COVID presentations for the ripe old age of 59 and higher. Some people are shocked when we use this number. It's actually interesting that if you look back across cultures and history, you will see that old age is generally considered beginning between 60 and 70. And if you look at the COVID curves, it probably is an okay metric to have 60 as the cutoff. What they showed was pretty interesting in that typical symptoms were the most typical, so that's great. Some typical symptoms were more common in older people, including the GI symptoms, the myalgia, the fatigue, and atypical symptoms were common too: dizziness, delirium, and anxiety. Now, for the dizziness, this has not borne out in other studies, and it probably had to do with the fact that most of the studies included here were from China, and dizziness, as you probably know, has very different connotations in different cultures. So a literal translation here, it is now increasingly thought that the word asthenia used in European studies meant the same thing. But the most interesting thing was that most studies were excluded due to improper separation of COVID-19 patients over age 60. So really hard to figure out what's going on if everybody's lumped into one great big pile. This was an incredible article in New York Magazine last summer, which sort of looked at the history of ageism in America, particularly in the post-industrial revolution era, which is when it's been at its worst, saying that nobody should be surprised. And I liked this line, which was that the horrific totals were not inevitable. So it wasn't just biology. The virus is an efficient killer, but it has accomplices. And then it's very specific about accomplices, particularly for New York and New Jersey, where governors calculated the risks in front of them. And when hospital beds ran low, they shifted the burden to those least able to shoulder it. So basically, they didn't allow transfers from nursing homes, and they sent sick older people who had come from home into nursing homes, which caused a variety of problems. One is obviously nursing homes don't provide the same level of care as hospitals. So the most at risk got the least high quality care, or not quality, but least appropriate acuity care. And they brought COVID with them into facilities that didn't have adequate testing or PPE. So yes, the virus is an efficient killer. And yes, our policies and decisions led to the slaughter of many, many older people. We see that among healthcare workers, race also makes a difference. Healthcare workers of color are twice as likely as whites to get COVID. Meanwhile, we're letting the bigwigs off the hook. So nursing home companies, and this has gone on, were misusing the federal support they were getting. So it wasn't going to hazard pay. Grocery workers, who already actually get paid a bit more and have greater retention than workers in long-term care facilities, were getting hazard pay in many cases. It was actually just going into the coffers of the wealthiest corporations. They also have a system whereby they can divert money from the clinical enterprise into real estate enterprise, and then it disappears, basically. We also saw how who you were made a difference. People who were more fortunate, who could work at home, who could not work at all, were able to liberate their parents from nursing homes where they were failing, bring them home and care for them there. But people who were essential workers and had to go to work each day were unable to do so. At this point, we began hearing that there was more than one story to shelter in place among older people, in any case. Increased loneliness, among some, but it really varied by subgroups. So not surprisingly, the people at highest risk were those with a history of mental illness, depression, anxiety, people with low emotional coping skills or low social support to begin with, people with higher functional needs that just simply weren't getting met, and who were declining to even greater functional needs with no real way of having those assessed and managed. At the same time, it seemed the majority of older people were adapting. All sorts of people, and you probably saw this in your practice and lives as well, who used technology in certain circumscribed ways, began using it in lots of other ways, and people who thought, that ship sailed, I don't really mind, learned to use tech. And that became a critical lifeline, both for exercise classes, for social engagement, all sorts of things. Somewhat coincidentally, a series of studies came out on low-cost tech-based care for depressed low-income elders, showing that with internet access and devices, low income and low education elders could also benefit from technology, that we could provide services, maybe not quite as good, but far better than nothing to them. And in general, it began to look as if older adults were more resilient than younger adults in pandemic. Oh, sorry, I meant to fix that. September, that great medical journal, the Washington Post, ran an article about deaths going up with people with dementia, particularly in facilities, for reasons that weren't necessarily related to COVID. So what was going on? They were having heart attacks, strokes, and lung infections, but weren't being sent out of their facilities, partly because their families were scared to have them go to hospitals, and partly because the facilities didn't want to send them out. There were phenomena such as rapid cognitive decline, falls, and sudden frailty occurring. Frailty does not happen suddenly by definition up until pandemic. And there were people who were starving themselves to death and committing suicide because they had so little hope for getting out of this. In all cases, such outcomes were worse in Black and Latinx elders. Prejudice continued. So this from Sharon Inouye and colleagues at Harvard, talking about the exclusion of older persons from vaccine and treatment trials. I like to speak about this one with a bit of a caveat because of the lifespan requirement from NIH to include older people in trials that went into effect in 2019. These trials actually did better than they would have, or 5 years ago. So that there were some older adults included. Often the cutoff was age 75 or 85, which was less helpful for people in facilities who tend to be much older, and for the people at highest risk, which was unfortunate. And then the ageism of medicine more generally, this from Tom Gill at Yale, tweeting about how JAMA did a viewpoint series to get people in, this was in September, to get people to think about where we were with pandemic, the experience, and it asked 11 specialties to comment, but no one in geriatrics, despite the fact that 80% of deaths from COVID were in old people. So, that degree of prejudice, can you imagine them speaking about women's health and including no women, or, PD? Yeah, it's just, it's appalling. Ageism is somehow excusable. This I liked. This is a case series from Paris. There are actually a variety of these that all show similar things. Somehow Paris struck me as a nice place to feature. So how did these ancient patients, so 85 and older, present? Asthenia, so-called failure to thrive, the dwindles in 3/4, fever in 3/4, but that means 1/4 didn't have fever. And if you're not going to test for COVID unless a person has a fever, you've got a problem. You're going to miss 1 in 4 cases. Delirium in nearly 3/4, not surprising, perhaps given the advanced age. An inaugural fall in 1/4. We had a big fight at UCSF about whether an inaugural fall in a person over age 70 could be an indication for a COVID test, and nobody wanted to listen. There was a lot of pushback. And digestive symptoms, again, a little higher than in younger adults. And this tweet from a young geriatrician in Boston talking about her patients. Me writing all my clinic notes, patient has declined significantly since the COVID-19 pandemic with new functional and cognitive impairments. Now this is into the fall. So you can see how you would lock down and not make provisions for health early on. But when you're 6 months in, how are we only treating the virus, as so many health departments were, or were we really thinking about the health of patients and populations? For many of us, we saw people with functional and cognitive declines that were preventable and treatable, but getting neither. On the other hand, a lot of people didn't have this. What I found speaking around the country is that it really depends on what sorts of patients a person takes care of. We again see the racial and ethnic disparities in COVID-19 mortality. This is in people aged 75 to 84 with very significant p-values, lots of good work on race and COVID and race and everything else from Mary Bassett. showing the rate differences of nearly 900-fold in Blacks, 500 plus in Latinx, 200 in Natives, and 150 nearly in Asian and Pacific Islanders compared to non-Hispanic whites. There is no biological reason to explain these rate differences. That's all society, policy, culture, healthcare. On the other hand, age does make a difference, right? So we really have to think about both. This was a great study that looked at two large cohorts in nursing homes to sort of prove what I first heard, a comment from somebody who was an Italian physician in this country who was reading, who could read Italian and was hearing similar reports from Italy over the winter, 2 winters ago. What they basically found was that in frail elders, if you used the cutoffs of 38 or centigrade or 100.4 Fahrenheit, you didn't trigger COVID-19 testing, that you had to use lower triggers of 37 Celsius and 99 Fahrenheit. This is the one change that actually does appear on the CDC senior care site. So some of the evidence has made it to the CDC, though very much has not. November, we began seeing in a variety of journals, this from emergency medicine, people talking about delirium and noting as well that you can see how different populations differ. So if you're talking about older patients, not just those over age 85, the incidence of delirium is low, but still significant. And also that nearly 40% of people in this study did not have any typical COVID-19 symptoms. This has been shown again and again. Older adults, here was a review in JAMA looking at all the studies 8 months into pandemic, showing that actually older adults might be less negatively affected. So this story begins to unfold increasingly as we go through the year. Now in December, this is slightly different data than we saw initially, but we see that there are really high risks for old people and really low risks for children. So if you use people in their 20s as the control group, 630-fold risk of death if you're over age 85, and a 16-fold lower risk if you're between 5 and 17. And yet this was and continues to be the CDC public-facing page, which talks about things you need to know, et cetera, et cetera. But the key part here is that they have a whole section on children and teens because they are, of course, different. We know this because we have pediatricians as opposed to internists, because we have children's hospitals and adult hospitals. And the pullout section for kids has 9 items. Now, given the rates of hospitalization and death from COVID, you might well expect to see a section on older adults, but if you look, you will see that it's not there. There actually are pages, but you have to go to people at increased risk, and then you go to older adults. And then it really is just about people with certain medical conditions, which could happen to you at 28 or 48, and other people who need extra precautions if they had congenital abnormalities, et cetera. It's slightly better now, but it still doesn't appear on the main page. There are a few pages, but really this shows the levels at which there just is lacking expertise and insight, and also equity. Because if you were giving information proportional to risk, things would look very different at the CDC web pages. One thing went right. When the vaccines came out, residents of long-term care were prioritized. On the other hand, here's where policy shows up again. The CVS and Walgreens got most of the contracts. They thought they'd be done in early January. Part of the problem was there was one system for all the rest of us to get vaccinated and a different one for older adults in long-term care. We know that separate is usually unequal, not equal. Separate but equal is a lie. The people making the decisions didn't know that pharmacies are already associated with long-term care, and so they invoked pharmacies that had ins with the White House, basically. You can find pictures of people playing golf with each other, and they didn't really have any expertise in this. So you began seeing in January all kinds of headlines about how slow the rollout was. Meanwhile, the biggest surge of all happens and people were dying and dying and dying. There was also, this is the distribution of how many facilities CVS and Walgreens had proportionally in California. Their footprints in California are equal, but CVS got way more contracts for reasons that are unclear. And consequently, sites that had contracted with CVS got vaccines more slowly and with more difficulty than those contracted with Walgreens. By February, we see that it does make a difference to have geriatrics because the risks, social, medical, and otherwise, are larger. Another failing here, another problem has been the complete ignoring of advanced care planning as part of this. Early on, we saw that getting intubated if you were 80 with 3 or more medical conditions was essentially a futile medical exercise. But rather than have advanced planning conversations with people, there was rationing instituted in places, whether it was not transporting people, refusing transport, or simply rationing ventilators. This could have been done in conjunction with palliative care in ways that did not require rationing, based on some studies that have really looked at what people would choose provided with the information on their chances. The rates of death are high, but most people still didn't die. So what are the predictors? And one is the hospital can really help you, but if you need a ventilator, you're probably in grave trouble. Vaccines made such a difference though. So this from the New York Times database showing the surge in the winter, but nursing home residents finally beginning to get vaccinated, and you see the plunge in red here. And this was the board in San Francisco. We had 3 of these full of outbreaks in assisted living and nursing homes. We're actually a very tiny city, so we don't have too many facilities. And then by March, we had none. In March, too, there was a great editorial by a psychologist in the New York Times looking at why older people managed to stay happier through the pandemic. And this is one of the great, all too well kept secrets of old age, is how much happier older people are. And what he talked about was that it shouldn't be surprising to anyone because people over age 50 score consistently higher or more positively on a wide variety of emotions. So they have more positive emotions in a given day and fewer negative ones. This is reminiscent of the U-shaped curve of happiness, which we have seen across most countries, except for the most impoverished, how happiness, life satisfaction go up with old age and anxiety goes down. Actually, I put this up the other day, but yesterday you may have heard that CMS and then CDC confirmed today that people don't need masks in nursing homes and other care facilities if they have been vaccinated. And older people are really starting to travel, as are others. But I think we can all think of Michigan as a cautionary tale, where lots of much younger people are now getting sick because they haven't been vaccinated, and probably in part because of travel. We also see the variants and the so-called double variants emerging in other countries. So are we completely out of the woods? It looks like many of the doubles, including the one spreading like wildfire through India at present, may not, the vaccine may not help. There have also been a couple of small outbreaks where people who had been vaccinated mostly had asymptomatic infection, but 1 or 2 frail people have died. I liked this from JAMA in February, saying that history suggests major crises such as wars, natural disasters, and pandemics can serve as tipping points for proactive action, collective action. And I think this is a great opportunity for all of us. I mean, with World War II came the UN, the World Health Organization, and the NHS in the UK. What could we do differently about race, age, and everything else based on what we learned or relearned from COVID? So I'm just going to close out with some lessons, and then I'll be really interested to discuss all this with all of you. So I would argue that we have a tremendous evidence base. There are 4 articles you can see below, but there is so much more, and this goes back decades. This was not just discovered in 2020, showing that healthcare, medical care, and medical research are racist, ageist, and one could still say sexist in some ways. The distribution of opportunity and power in medicine and healthcare is racist. This was why healthcare workers of color were twice as likely to get COVID. It had to do with their position, which had to do with their social opportunities. We also learned yet again that medicine can't be divorced from its social context. Making the social history kind of an add-on, burying it in the EMR, doesn't do anybody any favors, because what happens if the person can't refrigerate that medicine or can't afford it or must go to work? And this is just a graph showing Californians age 65 to 79 and how the distribution of deaths were very much racial in our state as well. We clearly need intersectional data. The CDC talks about age and sex and has been able to do age and sex data more intersectionally, but it hasn't added in race or geography or comorbidities or any of these other factors that are so critical in geriatrics and in medicine more broadly to understanding a person's social and biological risk. We saw yet again that ethical violations impact people. This is an article in JAGS from Jiwa et al. Talking about the basic principles of ethics that we're all taught as medical students and again, and how each one was violated in various ways in the era of COVID. We clearly need anti-racist medicine since we saw the different distribution, but that really has to do with society. There have also been studies showing that if you made it to a hospital, your risks were similar. So we can't really have health. I mean, I guess one question is, do we have just a medical care system? Like, you get really sick, we'll take good medical care of you. Although across diseases, we see racial differences there too. But if we really have a healthcare system, we have to think about our interface with society and social determinants. I also think we need to be more adept at providing trauma-informed care, not just because of the pandemic trauma or racial trauma, but in so many different ways, because we seem to be often part of the problem. In terms of ageism, that's also needed. If we're really going to have health equity across the lifespan, every time people are talking about services for kids and adults, we need to say to them, and what about elders? And whenever they talk about pediatric and adult care, we need to say, what about geriatric? It was well and obvious before, but if you look at COVID curves, if you look at a whole variety of COVID metrics, you will see that age makes a difference. And either we don't have an age-based system, so we don't have pediatrics either, or we do, and we don't undervalue older lives by treating everybody as if they were 40 in perpetuity. Again, a publication, this is from for those of you who don't know, Nature Aging is a new publication that's doing some interesting things in the aging sector, not all science. So this is an agenda for anti-ageist healthcare, which I recommend to you. I would make some changes, but since you're at a medical school, this could be some great changes to add into the curriculum at all levels of medical education. There can also be sort of implicit or more subtle ways that older people are attacked. So this is UCSF's diversity poster. It's everywhere, virtually and in person. It says, we welcome all races, religions, countries of origin, sexual orientations, genders, ethnicities, and abilities, but we apparently don't welcome people of all ages. In some ways, that's actually true of my institution. But I don't think they actually meant it that way. It's just so not on people's radar. And ageism tends to be that prejudice about which people from otherwise quite different backgrounds can agree. Here, I also have to point out that sometimes the people who mean well are part of the problem. The two banners you see here are from Boston's anti-aging campaign called Age Strong, based on Boston Strong and the marathon attacks. The top one is an 83-year-old man. You can see that he's already got some curvature of the spine, among other things, but he says he's a longtime boxer and he's many things, but not frail. He may not be frail, but if we talk about frail as something bad, as opposed to a natural part of the human life course, unless you die suddenly earlier, the fact is, if we live into old age, we will all become frail. And this is basically creating a world in which it remains not okay to be frail, and setting up a world in which this man, Vinny, in very short order, given the looks of him, will be one of those people who matters less because he's frail. Wouldn't it be so much better to create a world in which it was okay to be frail, in which you could still be happy and satisfied despite being frail? Similarly, the bottom panel talks about she's not over the hill, she's 86. So if we look at a bell-shaped curve of life, she is decades over the hill. I am over the hill. Many of us are over the hill. The problem isn't being over the hill, it's discounting the second half of life, which is just a waste of resources, time, and causing lots of unneeded stress. But meanwhile, the American Geriatric Society appears to be part of the problem. They say that words like aged, elder, and elderly and senior shouldn't be used because they connote discrimination. Actually look them up in the dictionary. What they mean is a human being who has been alive longer. The discrimination is what we bring to the words. The words are not the problem. The bias is the problem. And wouldn't we have a less biased world if we could actually use those words and it wouldn't be considered an insult? If people could use them about themselves with pride, or at least as a statement of fact. If you call someone's child a tween or a teen or a toddler, they don't look at you, offended and with distaste. If you call someone a young adult, they're not offended. It's because it's simply a statement of fact of where we are in the chronology of our human lives. So we need to tell the whole story. Yes, there are subsegments of childhood and subsegments of adulthood, but old age is not just one day you're 60 and the next day you're in a wheelchair. Old age is decades long and has very varied experiences. And we need to use those words as they were meant to, and maybe to parse them so that maybe you become a senior in your 60s, and then you're old, and then you're elderly, and then you're ancient or something, or aged. There's so many options, but we're not going to have policies. We're not going to have a health system that acknowledges this variety in elderhood if we don't have a language for it, or if we're not allowed to use the language for it. So this is San Francisco's anti-ageism campaign, the photograph on the upper left. And what it shows is the same people. You see them in old age in their eyes, and then their younger selves on above and below. And it basically shows that each young person is an old person in training, and within each old person is a young person. So we can all make a difference to create the old age that we want to live. And with that, I will stop talking, and I look forward to a discussion.
Louise, thank you. What a wonderful and inspirational presentation. I really enjoyed it very much. I'm sure our audience did too. So audience, please type your questions in the chat box and I'll moderate for our speaker. While we're waiting for questions, I just wanted to give a shout out to the healthcare community in Hawaii. All the physicians, the entire healthcare community, it's not just the physicians, really have done such an awesome job during this pandemic. And I want to give a special shout out to the geriatricians. We saw the disasters in nursing homes that happened across the country. And I'm not sure if most of you know this, but our faculty practice is primarily in nursing homes, and our faculty are medical directors at many of these nursing homes. They ran into some very challenging situations last year, with outbreaks, with times when we literally could not reach the Department of Health for a couple of days, when we could not get test results back for the longest I remember was like actually 2 weeks because it had to be sent to Texas. It was, we had some very challenging situations to deal with, and our faculty were resilient and came through it and really supported our community to make decisions that sometimes we weren't qualified to make, but we were the only people there to make them. And we did the best we could. And I think that's really helped the community. So thank you to the faculty. Also, our GWEP put on a series of education Zooms through the ECHO series. We started that in April of last year. And I think that was a huge success as well, because it provided training to nursing homes where the staff didn't even know how to put on a mask properly, some of them. I mean, it was that bad.
We saw that too.
Yes. So that really helps. So while I'm waiting for questions, anyone have any questions for Dr. Aronson? Surely this stimulated a lot of thought.
Can push back and disagree too.
I think, I know here in Hawaii, the Pacific Islander population has been disproportionately hit with COVID. I think they represent only 4% of the population, but they were 24% of the cases, and a huge increase in mortality, like tenfold over other ethnic groups. So we see that disparity even here in Hawaii.
Yeah, the groups can change depending on where you are, but the outcomes tend to be similar.
That's right. Any questions for Dr. Aronson? We've got a few more minutes. I see a lot of students and fellows.
Yeah, I recognize some from earlier, actually.
Yeah.
Familiar names and faces.
Please type your questions into the chat box, okay? One issue that's been coming up here, I think, is, we had a huge shortage of vaccination for a long time, and then now we actually have vaccines available and nobody to give them to, because we still have some vaccine reluctance. So I think that's something that we're working on. Is that something that's happening in California as well?
Yeah, it depends on where, and we're such an enormous state. There's still some counties. I mean, even, in the San Francisco Bay Area, like San Mateo didn't have enough last week, but other places have too much. And so then people who want it are driving to a different county to get it. But we're sort of seeing nationwide a plateau and a falling off of interest. And it seems to have a variety of causes. Part of it is people thinking like, oh, it's okay now, I don't have to do that. There's a lot of misinformation about, I don't know what you all are hearing, but that, mRNA can change your DNA. And, it's such a long scientific lecture about a piece of of RNA versus the DNA and where in the cell. And it's hard to have like a, not even an elevator speech, but it's some sort of like public service ad that could explain that adequately. And then there's also sort of just this who do you believe thing, which we've basically set ourselves up for with populations and with the disparities. Like, why should people believe people who have been part of a system that's done so much harm, as the data show. So there's just there's also a lot of information that I still hear about people like, well, I can't get it because I have diabetes, or I can't, so it's like the things that are the risk factors for bad disease are the reasons people aren't getting it.
I see. I do have a couple of questions in the chat box. So the first one is, one of the things I had a hard time dealing with regarding age disparity was getting vaccines, since so many of our older population don't have computers. And that was the main way that people were getting scheduled. Did that happen on the mainland, and how did they combat it? Because it's such a big obstacle for older people.
Hugely. Because people think, oh, it's so much more efficient. So there was a lot of noise made everywhere about you need to have a phone number. And we actually redesigned the whole city of San Francisco leaflets to actual pieces of paper. And initially they were just trying to give information, and we're like, unless you have a phone number and a real living person at the other end of the phone, this isn't going to happen. So sometimes what appears progress to some generations isn't for others, or for certain populations. So having phone lines really mattered throughout. Also, another big thing was locating things in the community, but sometimes people would also be oblivious about that. They'd say, well, it's only, 8 blocks away. Well, this 89-year-old isn't going to walk those 8 blocks, or the neighborhood isn't safe enough. So it was a lot about using paper and using telephone to get around some of that. A real shame that we can't do all those things simultaneously.
That's right. The other question was, why did the nursing home residents get Moderna instead of Pfizer? Was it related to availability?
Oh, so
This person's parents heard Pfizer was better than Moderna, but they didn't have a choice.
yes. So for us, we were told that it would vary. It depended on the supply, whatever the feds sent the state, and the state sent to the nursing, or the fed sent to Walgreens or CVS. So in California, you could get either one, and you didn't know which one you would get until they showed up that day. It's clear that they're both pretty good. If you look at the data, such as it is for older adults, maybe a few percentage points, what does that translate into? But the plummeting rates in nursing homes show that both work in older people. So we were initially concerned, how they've been doing trials in kids. Well, they didn't do trials in frail elders. They just said, let's give it to them. So again, there was this second class standard, like kids are worth doing studies before we do it. Adults are worth it, but for the very oldest and frailest, we're going to test on people who are less old and less frail, and we're going to give them the shots, but they seem to do well. So that's been great. And it may actually signal, if their uptake of mRNA vaccines is as good as it appears to be, another new strategy for increased vaccine uptake, because many of them, as we know from the 4 times stronger flu shot, don't work as well as we get older when we need them more.
That sounds good. The next question is, during the beginning of the pandemic, when so little was known about COVID-19, many worst hit areas had to ration care, and older COVID patients did not receive treatment. How is this going to be avoidable in the future? Or is this just going to be an example of ageism that's going to carry on? How can we learn from this for hopefully we won't have a future pandemic, but we always have to think like we might.
Yeah, hopefully this is ours if they come once every 100 years.
I hope so. Yes.
The case for me. Yeah, it's really interesting. Part of it was in federal preparedness and in our funding of the public health system, which has been in nosedive for decades. But also we had a federal government that was in denial about whether or not this was a problem, calling it things like the China virus. I'm from San Francisco, so you can imagine my political leanings, but nevertheless, there is also good journalistic data that was not helpful, and that we could have prepared better, although few countries did. And if we had prepared better, I highly recommend, and it's maybe a year old now, no, last fall, maybe it's a year. Anyway, Sid Mukherjee, author of Emperor of the Air, so the oncologist, wrote a piece for the New Yorker about, he started with what Japan did when they needed parts for something. Anyway, you can make factories do testing or PPE if you want to. Anyway, our federal response could have said, hey, this is almost certainly coming our way. It preferentially harms older people. We're going to need a lot of masks, a lot of tests, and a lot of ventilators. And it could have repurposed manufacturing plants to do all those things so that rationing wouldn't have been necessary. We also could have the sort of healthcare system, as I alluded to earlier, where we valued advanced planning adequately, that we could have been bringing people in to discuss risks and benefits and to get a better sense of what care people wanted. And then we could have been setting up different sorts of units. So people, often enough in very old age, people will choose aggressive care because they are miserable. And if you can take away the air hunger or the suffering, they then choose comfort, especially if their options are bleak. But we could have also just given people better choices. Had we started in December or early January with the manufacturing that would have enabled us to have enough equipment for everybody. You also imagine if you had put, like N95s into all nursing homes, or there's just so many things that one might have done and could learn from, and hopefully we will going forward.
Thank you so much. Well, this has been a really good discussion, an excellent talk, and I don't see any other questions in the chat box. So I wanted to say one more time, a reminder for everybody. Michaela has put the URL link for the evaluations. So please go ahead and click on that and do an evaluations. And I just wanted to say thank you again, Dr. Aronson, for such a wonderful talk. And for our audience, Dr. Aronson is also speaking tonight at JABSOM at 5:30 on her book, Elderhood, and that's even open to the public. So that's tonight, and we were really excited to have you here, and we enjoyed your talk very much.
Thank you.
Thank you very much. Hope to see you in person soon.
I know, that would be nice, wouldn't it?
That would be nice. Please take care. Stay safe.
You too.
Okay, bye-bye.
Bye.